evening to all.
Hello, good evening, everybody.
Okay.
Good evening, Dr. Basab.
Good evening, Ashok. Good evening, Professor Omondi. Good evening, all members of KOGS. It's a pleasure connecting.
Okay, good evening to all. I can see our guests are in, and I think we have about 115 plus participants, which is a good number. This is across the obs and gynae fraternity in the country and maybe some parts of the region. I'm privileged.
Sir, your voice is very less, sir. Not able to hear, sir.
You're not able to hear me. Let me now make more noise. Is it now more audible?
Better, sir, better.
Okay, thank you for that.
Thank you, sir. Thank you.
Yeah. Today we are having a very important session we are going to have today. And as I just mentioned that we're having attendance across the fraternity of obstetricians, gynae in the country, and also quite a sizable number of our residents all across the medical schools within the country, and also some I can see are also outside the country. So that tells you that it's a very important subject and everybody is willing and ready to listen to what you are going to say. I'll leave much to the organizers to be able to mention a few. So maybe I'll give Ashok maybe a few minutes to give us some opening remarks. Then I can be able to then open the session and thereafter invite our speaker, Dr. Basab. Remember, India is 2.5 hours ahead of us, so it's a bit late for them in the evening, so we want to make it as quick and sweet as possible. Mr. Shok, welcome.
Yeah, thank you, Professor Omondi, and we are really honored and obliged to address or to be a participant in this kind of forum where very learned doctors like you and your colleagues are there, not only from your country, but only right now, I just now saw that somebody from Zambia and our teams have joined from Uganda and other countries as well. So really honored. So just give me, I need just 4 or 5 minutes to introduce ourselves or our company to you. And then we can pass on the baton to Dr. Basab Mukherjee to start the session. So just give me a second. Let me share my company presentation. I'll just take few minutes of yours on that so that can you see my screen, sir?
Yes.
Okay, thank you, sir. So namaskar from India. Good evening, everybody, and welcome. I just want to take your few minutes regarding the company presentation. We are a relatively very new company. We started operations in just 2004, but only 19. We are still in our teens. And now by the year 2023, that is, in fact, this financial year closing, we crossed $500 million worth of sales, and we have become India's largest contract manufacturing company with 13 finished product manufacturing plants and 3 API plants as well, and manufacturing 5,000 products in our facilities. This company is promoted by Mr. Sanjeev Jain and Mr. Sandeep Jain. These are two brothers. We manufacture virtually everybody for everybody in this country, in our country. All top players of Indian pharma industry. We are basically a contract development and manufacturing company. All top MNCs which are existing in this country, be it Novartis, Sanofi, Mylan, Allergan, GSK, Abbott, UCB, and Menarini, and wellness players like P&G, GNC of America, and likewise Oriflame from Sweden, and many other homegrown companies as well. These are our facilities. These are 12 of our finished product manufacturing facilities. Plant 1 for oral solids, plant 2 for liquids, plant 3 for injectables, eye drops, plant 4 for female hormone products, plant 5 for dermatology and cosmetics, plant 6 for nutraceuticals, 7 for multi-dose, different kind of products. And this plant 7 is the largest plant in Asia in terms of the number of units produced here in a month. And then plant 8, plant 9, 10, 11, 12, and there are 3 API facilities as well. We manufacture virtually every dosage form which exists in this country, be it all kinds of tablets, powders, sterile preparations, topicals, oral liquids, and capsules and sachets also. We have so many global accreditations. Our plants are approved by European GMP, and then TFDA, then PPP Kenya, and we are there across all Eastern Africa, as well as West Africa, as well as Southeast Asia, Latin America, and CIS, that is Russian subcontinent as well. These are some of the products which we manufacture. Some of the very renowned products like Limsi is #1 vitamin C brand of India. We manufacture it for Abbott. Sustain, which is a #1 progesterone brand of India. We manufacture it for Sun Pharma, and everybody, I'm sure, will be very surprised to know that we manufacture 450 brands of progesterone. That is, we manufacture progesterone for 450 companies in India. That is the scale of our operations, just to share with you. And for so many products for Glaxo, that is Eno, which is very famous in this country, and many other products. We are a fully integrated company in terms of meeting all regulatory requirements and creating innovative solutions or formulations. We have very robust quality systems and high standard of integrity and transparency. This is about our R&D structure. We have 4 R&D structures. Our key strengths are, as I mentioned in the first slide, we have more than 1,000 clients around the world. We have made 400 first time in India products for these R&D facilities. And then we can say so many formulations, 4,200 formulations manufacturing. We manufacture 13% of this country, that is our country, India's total drug consumption. This gives a complete indication about what is the size of our manufacturing. Filed patents for 85 products. We manufacture 16,500 brands and 12 plus 3 facilities, manufacturing facilities. And then our global presence, we are there in more than 50 countries across the world. As I said, we are there across East Africa as well as West Africa, Southern Africa, and Asia, Latin America, CIS. And now we are venturing into Europe as well from this year onwards, because our plants have become Europe approved. And that's all about us. Thank you. Thanks a lot for giving us time for presenting ourselves. Thank you, sir. Over to Professor Omondi. Sir, Dr. Omondi, sir. Over to you,
muted.
sir.
I was muted. Thank you.
Yes,
Thank you for your introduction of your company to the participants, so that at least they have an idea of what you do and what your company is made of. Now, I'm sure some of the questions will come in relation to some of the products you are involved in the manufacturing, and I can see some of them are marketed by other companies and yet you seem to be the primary producers. Before we go to Dr. Basab's presentation, I'll just make 1 or 2 comments. The subject matter today is a very interesting subject. It's one subject which most people think they know so much about, and yet the more you delve into this subject, the less you realize that you don't know. And therefore, each and every day as you manage patients is a learning experience. And for anybody who would want to look after patients with pregnancy failures, you must really be able to understand the physiology of pregnancy, physiology of what happens within the endometrium to start with, and then the rest of the things which happened within the first few weeks of a pregnancy, because that is where trouble starts. And therefore, as we know, more than a big percentage of pregnancies are lost even before the women know that they have lost a pregnancy. And therefore, as a clinician, when these patients come to you, you really have to be on your toes to really know what are some of the potential causes of the recurrent pregnancy losses, or what are the potential causes of failed implantation, of which there are several. You will categorize them in different ways. I don't want to go into the details. Dr. Basab will take that subject, and I would like you to take note of all the questions. I didn't want to give a presentation today because we'll end up just duplicating what I would say and also what Dr. Basab would say. But we want to give Dr. Basab the chance so that he gives us a presentation on what he knows or what he has been doing in the subject, of which he is quite familiar with and very experienced in. And also, we will be able to take care of the pitfalls which we always go through. We agreed with him that he will try and make the presentation as simple and easily understandable as possible, so that you have got enough take-home messages and you have got enough information so that you can be able to tackle that patient you saw maybe 1 week, 2 weeks, or even yesterday, and therefore you can challenge yourself and see what is it that can be done. We know that each and every country, because we are having gentlemen from across the country, from Ndola in Malawi, Zambia, Uganda, and we want to have a commonality in management of these patients. So I'll give the floor to Dr. Basab. Now, Dr. Basab is the director of Ankuran Fertility and Fetal Medicine Center, which is in India. He's got quite a long CV, but just remember some of the key things about Dr. Basab. He has been the vice president of FOGSI. For those of us who are members of KOGS and also FIGO, it's always known that anybody who wants to be elected as a FIGO official, you must get the votes from India, because India has got one of the largest number of gynecologists, the whole one, and therefore I think they have got about 14 votes in the General Assembly of FIGO. Maybe the numbers increased recently. He has several awards and achievements. Yuva FOGSI Orator 203, Dr. Duta, Best Publication 2017. He's been Secretary of BGOS. He has received several FOGSI awards, and he's also a member of the Family Planning and Ministry of Health and Family Planning in India. And for interest in the academic world, he has been a clinical examiner of MRCOG Part 3, amongst the many other things. Apart from that, Dr. Basab is an acclaimed academician. Dr. Basab, I'll give you the field.
Thank you,
Keep
Professor.
your questions, and you can put some of them in the chat. So you put your questions in the chat as he gives the presentation, then you can be able to go through them at the end of the session. Welcome, Dr. Basab.
Thank you, Professor Omondi. Thank you very much. I'll just start with sharing my screen, and then we take it from there. Thank you, Kenya OBGYN Society. Thank you, ECMS, for bringing us all here together. And we will have some discussion over the next 35 to 40 minutes, of which 20 minutes will be our speaking time, and 20 minutes we assume would be some questions which we can all learn from each other. And that is the idea. That is the plan today evening. So my talk would be around 20 minutes, and another 20 minutes we will be having some discussion about some ways in which you manage early first trimester pregnancy loss, and we look forward to learning from each other in this session. So nearly 10 to 15% of all clinical pregnancies and 30% of all pregnancies terminate with spontaneous abortion, and making it the most frequent pregnancy complication. So all the time we do not understand it because we only look at the clinical pregnancy loss, but there are a lot of subclinical pregnancy loss, or biochemical pregnancy is what we used to call them, and that is roughly 30% of all pregnancies, and that is what is terminated and has a spontaneous abortion. So early first trimester pregnancy loss is the topic. Over the next 15 to 20 minutes, I'd like to take you through two parts of it. So one is the spontaneous loss, which is something which can happen as a one-off thing, which is quite frequent. And one is a recurrent pregnancy loss, especially early in the first trimester. And that is what is interesting, and that is what is challenging, and that is what is worth discussing. And I think we will be spending some time on that topic. The etiology and pathogenesis, as Professor was mentioning, that is so important to understand why exactly it happens. We won't be going into the deep scientific details, but we'll be trying to leave some important messages which will be helping clinicians about how to deal with the different things when they come to you and present to you in a healthcare setting or in your clinic. So how to prevent a pregnancy loss from happening, how to treat it. If you have already had a pregnancy loss and the woman comes again pregnant, what are the precautions which you can use? What treatment can you offer to her and to help her to continue with that pregnancy based on some of your experience and a lot of evidence which has been generated from research all over globally. And then managing the loss as it happens. So if a woman comes to you with bleeding in early pregnancy where the pregnancy is lost, or there is not much of pregnancy there left, then how do you manage and what you do? This is something which we all do in our clinical practice, but we'll just go through the points there. So we know something very from our undergraduate days and postgraduate days, that as mothers grow older, the chance of getting pregnant becomes more difficult. And if she gets pregnant, the chance of a miscarriage also proportionately increases. So there was a textbook quite some time ago which we read, which mentioned that the best time a mother can become pregnant, or the best age of getting pregnant, is roughly around 24. And this is one of the reasons why it's 24, is because your risk of miscarriage is less. And at that time, possibly medical problems are less. But we are living in a different world. People don't get married or get married after 30. And so getting children at 24 is a thing of a lot of the past in a lot of the modern generation. And so we do face a lot of times when women come later in their life, reproductive life, and they come with miscarriages, many, and then we have to tackle them and we have to deal with them. So the risk of miscarriage, we know, increases with the number of previous miscarriages. So this is one of the greatest risk factors. If you have one miscarriage, you may have one more, or you may have more than that. So with 0 miscarriages, you have a 12% risk of miscarriage. With 1, it's 24, 2, it's 26, 3, it's 32. So 4 or more, it's 40 to 50%. So that's just one point we want to mention here, that even after 3 miscarriages, if you don't do much or you don't investigate very seriously, there is still a 65% chance that this woman, when she becomes pregnant for the 4th time after 3 miscarriages, will go on to have a live baby and a healthy pregnancy at the end of it. So it's not all the time that you have to go through the investigations and try to find out what exactly went wrong. A lot of time nature will come into the picture, and you have a chance after 3 miscarriages, roughly 65 to 68% of the next pregnancy being a normal pregnancy where a woman goes to deliver at home. Women with no live children, 2 or more, again, there's a 40 to 45%. So what are the different factors or different etiological causes of recurrent early pregnancy loss or pregnancy loss in general. So there is a genetic factors which we will be discussing very shortly. 10 to 15% of anatomic factors. And what are the anatomic factors? How can we detect them and what can we treat them? And how useful is treating them is something which we'll be touching upon. The autoimmune issues. Infections once upon a time used to play a major role, but over time we understand that infections possibly is not as important as we used to find it. Especially there was a very big craze of doing the torch parameters, the toxoplasmosis rubella at one point of time, but now we know that torched investigations are not indicated in a case of recurrent pregnancy loss. They may explain an isolated loss, but not a recurrent pregnancy loss. And then 17 to 20% are endocrine factors, where again the elusive luteal phase defects, the thyroid disorders all do come into picture, and we will be highlighting them in this presentation. But an important part in the green portion of this circle, as you rightly see, is that irrespective of all the tests and all the investigations you do, 40 to 50% of miscarriages remain unexplained. And this is something, even with the best of the laboratory investigation and the best of the knowledge in this present moment, we find that this is very difficult for us to explain patients when you really cannot find any cause, and they are not very impressed when you do not find any cause, and they really want an answer to many things. So recurrent early pregnancy loss has a complex health challenge with no uniformly accepted definition. So RCOG will say 3 losses, ESHRE will say 2 losses. We do not know what loss is it there. Then again, at what gestational age is the loss? Is biochemical pregnancy considered a loss? 12 weeks loss, 24 weeks loss, are they all the same? So there is no uniformly accepted definition, and it is a complex health challenge. The true incidence varies from 1 to 5%. It's difficult to estimate because there's no uniform definition. People define it variably. And also they define it variably as when to start investigating or when to find out what is wrong. Sometimes people want to do it after 2 miscarriages, some people want to do it after 3, and some people, even if it's a one which is obvious, some people may even investigate after 1. If it's a viable pregnancy, a woman where the heartbeat was seen and the heartbeat goes away at 13 weeks, and she's an elderly lady, a lot of times you may not want to wait and you want to go and investigate. So it all depends also on the discussion which we as clinicians have with our patients. It is not that it is written in some guideline that you have to do investigations after 2 losses or 3 losses, and we wait for her to have those 2 and 3 losses. Sometimes we may, in our clinical knowledge and in discussion with the woman in front of us or the couple there, that we may need to do it earlier. So polyetiological and multifactorial conditions are involved. There are a lot of reasons, and it is not that, as we showed in the previous sphere, it's not that all the time it will be one. There may be more than one reasons for one particular woman to having repeated miscarriages, and it has to be taken care of. As we had described already, more than 50% remains unexplained even after a thorough evaluation, and that is something which is of a big challenge to the healthcare provider. It has an enormous impact, as Professor was mentioning, and frustration, both on the part of the couple who is presenting with you and the healthcare provider who is trying to find an answer to the problems. So this is one of the different charts which we picked up, which is showing different types of reasons why recurrent pregnancy loss happens earlier in the age. So maternal age, uterine pathology of different kinds, genetic anomalies, infectious agents, endocrine disorders, thrombophilia, immune pathology, vitamin D deficit has not been very clearly associated, but we do try to counter vitamin D deficiency, which is very rampant in India, and other factors, the lifestyle issues, which we will be touching upon, and as we have mentioned, the idiopathic consequences. So let us look at each of them just briefly. We won't be looking into the details of anything, but we'll just give an overview about, let's say, genetic anomalies causing recurrent pregnancy loss. So this is something which we know. And the question is, should we be doing a parental karyotyping, and should we be doing a chromosomal study of the products of conception? So what is the correct answer, and what does the evidence at this point of time tell us? So cytogenetic analysis, according to the RCOG, because those was the latest guideline of 2023 compared to the other organizations which guidelines were slightly earlier, cytogenetic analysis should be offered to the pregnancy tissue or products of conception of the third and subsequent miscarriages in any second trimester miscarriage. So the first trimester they're not mentioning, second trimester they're mentioning. So that test should be sent for examination. And parental peripheral blood karyotyping, which at one point of time was routine to do for everybody, should be done in whom the testing of the pregnancy tissue reports an unbalanced structural chromosomal anomaly, or there is unsuccessful or no pregnancy tissue available for testing. So suppose she has a complete abortion at home and then she comes to you, obviously you won't have anything to test. Or if you've given her some medicines for abortion and then she has come, then you may not have anything to test. In that case, you may be looking at peripheral, but mother and father's blood karyotyping. But otherwise, cytogenetic analysis of the pregnancy tissue is something which is recommended usually after 2 or more miscarriages. So this is a small chart on the same idea of what we have discussed. So if there are 2 or more miscarriages, then there is a point of doing a cytogenetic analysis of the products of conception. And depending on what you get from this result, what you need to do further is what is decided. So if it is a euploid karyotype, means there is no chromosomal problem at all, then possibly you would look for the other reasons why there is a miscarriage happening. So we know that 80 to 90% of miscarriages in the first trimester happens due to chromosomal anomalies. And chromosomal anomalies could be of different types. So if it's not a chromosomal anomaly, then you have to look at something else. If it is a chromosomal anomaly, then it could be an unbalanced chromosomal translocation or inversion, and in this case you would like to do a parental karyotyping. How would you be able to get this diagnosis? Is by a chromosomal microarray. So you will not get it by karyotyping. You'd have to do a CME, chromosomal microarray. If it is not available in your place, then it is no point of doing maternal karyotyping just by itself. So this is something which is important. So if it's an unbalanced chromosomal translocation or inversion, then you offer parental karyotyping. If it's an aneuploid karyotype, there is a suggestion of doing PGT or pre-implantation genetic diagnosis, which again is not very common, is only available in IVF clinics, and that is something which has been suggested. The next thing which we will move into is the uterine anomalies causing recurrent pregnancy loss. So there are 2 types of uterine anomalies. One is the congenital ones, which are the ones with the Mullerian anomalies, which all of us are aware. And the one which is the most spoken about in the context of miscarriages is the uterine septum. So the uterine septum is the one which is most commonly mentioned. And so how do you evaluate uterine anomalies? One of the best ways of doing that is a 3D ultrasound, but a 3D ultrasound may not be available all over the place. So you can have a 2D ultrasound, a transvaginal ultrasound, of course, where you can see better, and that would give you some idea about the uterus. Whether you can do a SIS, a saline infusion sonography, or an HSG, yes, that would be another alternative if you don't have a good 3D ultrasound, which will give you some idea about whether it has got a septum, whether it's an arcuate, a biconuvate, didelphys, or some Mullerian anomaly which you can identify. Of the different anomalies, the one which is most associated with pregnancy loss is a septate uterus, where it can be considered to do a resection. And that is something which is shown to be helpful if it's a woman who has had miscarriages. So if a uterine septum is seen incidentally, that does not carry any weight. But if it's seen in a woman who has got previous miscarriages, there is a point of doing a resection of the septum. And this is something which has a lot of studies going on. Also in uterine anomalies, there may be small fibroids or polyps which are sitting in the cavity, which need to be cleared and removed, which is best done by a hysteroscopic route. Coming to the thrombophilias and recurrent pregnancy loss, women with recurrent pregnancy loss should be offered testing for acquired thrombophilia, particularly lupus anticoagulant and anticardiolipin antibodies prior to pregnancy. And this is something which is best done in a standard lab, because there's a very important message here that the laboratory where you're doing the testing should be very good, because they should know what exactly they are doing. Women with second trimester miscarriage may be offered testing for factor V Leiden, prothrombin gene mutation, protein S deficiency, ideally within a research context. And so the two types of thrombophilias, one is inherited and the other one is acquired, of which inherited ones have a very weak association with recurrent miscarriage and does not fit into routine testing like protein C, antithrombin deficiency, and methylene tetrahydrofolate reductase mutation. But the acquired thrombophilias, which is more commonly associated with recurrent pregnancy loss and has very rewarding treatment when we use heparin and aspirin for them, would include lupus anticoagulant, anticardiolipin antibodies, and beta-2 glycoprotein. So for thrombophilias and recurrent pregnancy loss, women who have been identified with this problem should be offered aspirin and heparin from the time of a positive pregnancy test till at least 34 weeks, with benefits far outweighing the risks. So it should not be given to women with unexplained miscarriage, and we will be coming to the unexplained miscarriage in a minute, and then we will be discussing something about that. Low dose aspirin, how much? Usually depends on what is available in your country. In India, we use 75 micrograms because that's the tablet which is used. There's a lot of Western literature talks about 81 because that's what's used there. And the heparin usually we talk about is a low molecular heparin instead of injectable one. So the low molecular you can give subcute, and it's just something more convenient, and that can be continued till nearly term. Coming to some other factors for recurrent pregnancy loss, one is the immunological factors. We do mention about it, and the immunological factors, there is little bit of evidence to suggest that it can be routinely offered. So whether it is screening or whether it is treatment, though immunological screening is something where a lot of research is being done, and maybe a lot of things where we have the idiopathic now may come in the at a later time, that immunological causes may be more prominent. But till then, we are still yet to understand this at a very detailed way. So the HLA, cytokine, natural killer cell tests are all reserved for now. Even the sperm DNA testing, a lot of people at one point of time, spoke about fragmentation, DNA fragmentation being a cause of recurrent pregnancy loss, but the evidence is not very strong about the association. And even if it has got some association, there's not much of idea about testing, about which medicine to take and how to really prevent it. Coming to the last part of this discussion about endocrine factors for recurrent pregnancy loss. And in endocrine factors, you talk about thyroid functions and you talk about progestogen supplementation. About prolactin, well, yes, increased prolactin is one of the different causes of miscarriage, not usually recurrent, but that needs to be checked and corrected. About thyroid function tests, it's good in a case of miscarriage to assess for thyroid peroxidase antibodies. And if you have a hypothyroid patient with TPO antibodies, then there is definitely a role for thyroid supplementation, but not for a euthyroid woman who has a TPO antibody. So that is something which is mentioned very clearly. If she's euthyroid and she has TPO, then that doesn't mean that you'll be giving her thyroxine supplementation. But if she is hypothyroid, then of course you'll be offering her. Coming to the very important part of progestogen supplementation. Progestogen supplementation is considered in a case of threatened miscarriage, in a case of recurrent miscarriage, in a case of luteal phase defect, and there is a lot of buzz among progestogen supplementation globally. Of course, in India, I'm sure in the African Union too, and that is something where progestogen supplementation, it should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy. So we'll be coming to some of those studies here, and that will be trying to make it more clear. But for example, 400 micrograms of micronized vaginal progestogen given twice daily at the time of bleeding until 16 weeks is one of the different ways in which you can prolong the pregnancy and try to reduce the miscarriage rate. The other progestogen which we can use and which we often do use is oral dydrogesterone, which is compared to the vaginal micronized progestogen which is used. So one of the trials which earliest did this progestogen in recurrent pregnancy loss was a PRISM trial published in NEJM in 2019, which was a randomized controlled trial of 4,153 women, where women who presented with early pregnancy bleeding were treated with vaginal progestogen versus placebo. So this was actually directed for women with threatened miscarriage, and they showed that there was not much of improvement in live births. But if you had a subset of group of women who had a previous miscarriage and then had early pregnancy bleeding, they do benefit from progestogen. And the more the number of miscarriages, more is the benefit. So women who had one miscarriage and early bleeding had some benefit, 2 had more, 3 had more. So that is the reason why it's very clear that if a woman had previous miscarriages and has early pregnancy bleeding, then it is good to provide progestogen. So similarly, this also had come from the Cochrane library, Progestogens for Preventing Miscarriage Network meta-analysis review, and they all have suggested that progestogen is a therapy to consider for both recurrent pregnancy loss, early pregnancy loss, and in threatened miscarriage. So this came out from the RCOG a few years ago, 3 years ago, and so progestogen could prevent 8,450 miscarriages a year, finds new research. Coming to the last part of this talk, the unexplained RPL. Though unexplained losses are generally frustrating, we saw that around 50% or more of cases of recurrent pregnancy loss, we do not know what the cause is even after the best testing. The prognosis is generally good in type 1, where there's no underlying pathology seen. Tender love and care, which was once championed, has little evidence to support it. Though it always doesn't cost anything to render tender love and care, often we see that a lot of support, once you do a lot of support in a case of recurrent pregnancy loss, women do respond positively. That is the general feeling that most of us get as practitioners, though there is a little evidence to suggest the same, but it doesn't cost us anything to show a little bit of empathy and a little bit of just to spend some more time, some more minutes with a patient who is in this position. Progestogen and possibly HCG may have a role in prevention of unexplained RPL and increasing live birth rates, but studies are on and evidence is still patchy, and we need to look at further evidence. Coming to the psychological impact of recurrent pregnancy loss, yes, it is a distressing life event for the woman and couple. And though we are clinicians and gynecologists at the end of the day, it is also that we are healthcare providers, and we have to look at the woman and the couple as a whole, and we have to look at the psychological impact of this recurrent pregnancy loss on the woman. We cannot just put it under the carpet. She would be going through grief, guilt, fear of the future, relationship conflict, marital distress, poor personal adaptation. And if we don't take care of this, if we don't address this, then it may lead to psychological and psychiatric problems like stress, depression, anxiety, and severe morbidity. There is limited publication on psychological interventions on adverse pregnancy outcome, and this is something which we should all take care of. The last slide is the supportive treatment in RPL. They should be advised to maintain a BMI between 19 and 25. So lifestyle modification, smoking cessation, limiting alcohol, limiting caffeine, do all go for a very big role to play in managing patients like this. And ideally, they should be taken into a setting of a dedicated recurrent thing. Managing the loss as it happens. So if a woman comes to us with the bleeding at the time of the loss, what do we need to know? We need to know that the woman is hemodynamically stable. So if she has a lot of blood loss and she has tachycardia and low blood pressure, you need to admit her because you need to resuscitate her. Or if you can manage her as an outpatient, if it's just like a normal period. If it's complete or incomplete, you need to know. If it's incomplete, then she may need clearance, which may be medical or surgical. If it's complete, then it's fine. So an examination could show an open os or closed os, and imaging can give you some idea whether there's retained products of conception. If she has a low hemoglobin, there may be a point of giving a blood transfusion or parental iron therapy, which is quite common in India nowadays. And need for uterotonics and antibiotics may be there if it's an incomplete or it's done or a few days ago, and there may be foul-smelling or foul-smelling odors, then definitely she may need antibiotics. Again, as we said, assess the psychological impact, the necessary support, collect notes for future management and the next pregnancy planning. This is not what is over. This will go on, and so you really need to know what exactly went wrong so that you can manage her better. So the final take-home messages before we wrap up: pregnancy loss is recurrent, is a traumatic life event that affects a woman's physical, psychological, and social health. Management should be offered to women on the diagnostic findings and existing guideline recommendations. Studies to identify the etiology and risk factors of recurrent pregnancy loss, especially idiopathic, should continue. I thank you very much for this opportunity, and we look forward to having some discussion on some questions. I'll just finish this. Yeah. So thank you very much. Any questions? We'll be love to discuss it together. And I thank Kenya Obsgyne Society and ACOMS for bringing us all together. Over to Professor Omondi, please.
Thank you, Dr. Basa. What a wonderful presentation. And you have made it quite simple, neat, and very, very nice. Am I lost? Sorry, I almost thought I was lost. You have made the presentation simple, neat, and nice with lots of take-home messages. And maybe I just want to make one or two comments on what you have said. I'm quite happy that you have actually emphasized about looking at some of the issue of doing chromosomal analysis in most of these patients who have had pregnancy loss, because I always say that a woman who has had a pregnancy loss and you are taking them in to do, maybe we decide to do uterine evacuation, then most people take specimens and send them to histopathological evaluation. Of course, the pathologist will tell you these are products of conception. That does not help you to understand what could have happened. We know we don't have facilities for doing chromosomal analysis locally, but you can always send the specimens out of the country. It's a bit expensive, but it will give you some information so that at least you know where you can be able to factor in your pregnancy loss, which is quite an important thing, because you know chromosomal analysis, if you widen the scope of the causes of pregnancy losses, recurrent pregnancy losses, they amount to almost 15 in number. 14 you can pick up possible causes. Then you have the 15th one is the unexplained, which is almost contributing the same number as almost half of what causes contribute to the other 14%. We are able to do lupus anticoagulant locally, not in the maybe in the big hospitals. I just wanted to make a comment also on the issue of recurrent pregnancy losses related to what happens within the endometrial cavity, especially as to what the role of the natural killer cells are as part of the aspects of what happens within the endometrial cavity. Is still at research levels. It's something which I'm working on, and very interesting results are coming out. And most of these women, you find that there's a lot of derangement in the functionality of the uterine natural killer cells. They may be having the correct numbers, but their functionality is affected, and therefore need to be able to do the correct treatment after you have gotten the results. But as you said, it's quite expensive to be able to do this, but it is something which maybe as more information comes out, the cost element of doing the testing may come down, and therefore many women can be able to benefit from that. Let's see, there are some questions on the screen. I'm trying to see what is in the chart. Can you be able, Dr. Basa, can you read the chart and maybe respond to those questions instead of if
yes,
you have
Professor
it?
Omondi, we have a question. We have a question from Harmeet Dhadiallah about at what stage of pregnancy would you recommend starting luteal progestogen support? So I think what we discussed was luteal phase defect is something which is very ill-defined, and a lot of it is assumed. So when we usually would start support after a positive pregnancy test or after seeing the fetal heart rate, one of the two would generally be the thing. So a lot of us do it when it's a positive pregnancy test. Some people do it after the fetal heart rate is seen, but whichever you do, that is when luteal phase support would normally be given. Then there is a question on what is the role of estrogens in early pregnancy loss. I would not know of any role of estrogens in early pregnancy loss. Professor, if you have an idea, you can share here. What sperm DNA fragmentation, I had already mentioned, is one of the recent causes which has been identified as an association with miscarriage. But if it's an association, it's fine. But there is not much of treatment of sperm DNA fragmentation. A lot of antioxidants and lifestyle measures have been introduced, but it hasn't shown to have a positive effect on preventing or reducing miscarriage. So there is an association possibly, but unless there's a treatment, just an association doesn't usually help. But if you want to get an answer, sperm DNA fragmentation, there is some studies, but it hasn't yet come into the recommendations. So sperm DNA fragmentation is a lot of buzz in the research media. We may have to watch the space. Maybe in some years, it may come into as a recommendation that it is a good test to do to find out whether that would be one of the different causes. Professor.
Okay, the role of estrogen in pregnancy loss. Estrogen function together with the progestogen is to ensure that the building up of and maintaining the luteal phase. So if you have got low estrogen levels, you will not reach that level. So even the process of pregnancy or implantation will not occur. And remember, when you are talking about pregnancy loss, it's different from talking about the endometrial levels or the endometrial thickness. We are talking about situations whereby there's been implantation and then you have got a pregnancy loss. That is where the estrogen levels, if they are low, then you'll end up with thinning of the endometrium, and therefore you may not be able to get adequate luteal phase. So it will prevent pregnancy. It does not even allow you the luxury of implantation and thereafter having a pregnancy. So in those patients who have got thinning of the endometrium, you'll have to work on that before even you entertain pregnancy in these patients. Dr. Bass, you can comment on the HCG. What is the role of injecting HCG? I think those are some of the other newer questions.
Yeah, Professor Omondi, I think one point of time HCG was extensively used, but there has been limited evidence, and it's the fallout recently that HCG, progestogen is better than HCG to be used in most cases. So HCG use, which was quite rampant a few years ago, is now losing pace. So it's not much of HCG, it's more of progestogen. So the micronized progestogen in the vaginal form or the oral dydrogesterone are one of the two choices.
What would be your comment on HCG, especially in those patients who have got subchorionic hematoma, hemorrhage, and therefore you are having range function of the developing placenta where you start getting levels coming up at the chorion levels? Would giving HCG, exogenous HCG, help stabilize the area where the bleed is going to come, where the bleeding is coming from, and if you use it together with the progestogen as a combination?
Yeah, it is possible, but like as we said, as the professor you said, it's more theoretical and biological rather than research proven. So what you said makes absolutely logical sense, because what we would be thinking as clinicians will be something in the same lines, but there's not much of research to back HCG being a useful intervention for subchorionic hemorrhage. But at the same time, I do take your point. Even though it has not been proven to be beneficial, it has not been proven to be harmful either. So sometimes we do offer medicines when we are a little desperate and we want to do the best for our patient. So sometimes we do use injections, HCG, even though knowing that it has limited benefits. So I'm sure that there is a point which you are making where you may use some interventions, even by a clinical experience and by just logic coming into the picture in the best interest of the patient.
Okay, there's some questions you have answered on the chat, but I'm sure there are some who are using their phones, their smartphones, so they may not be able to read. Maybe you can respond maybe orally on the question from Dr. Veronica Nyirongo, most I think from Malawi or from Zambia, one of the two countries.
Yes, I think I did mention about, yes, because she has mentioned a point that it is recommended to karyotype for a second trimester pregnancy loss, is what I had read were the RCOG 2023 guidelines. But she's made a very important point that it's mainly first trimester losses are the ones which are associated with chromosomal anomalies. And it would make perfect sense to have first trimester products of conception to be sent instead of second trimester. She's made a very important point, which I agree. And that is something which we also do in our clinical practice. If it's a second or third miscarriage, usually we would be collecting the first trimester products and sending them for evaluation. But again, it will only be done if you have the chromosomal microarray facility in your setup or in your city or in some place where you can send it, where a reliable report can be expected, because there are problems also in collection. How will you collect it? What will you transport it in? And those are issues which has to be cleared before you give the POCs for testing.
Okay, maybe I'm sure the audience would want to hear more from you on the role of vitamin D, because we know that earlier on from the 2019, 2020, 2021, there were lots of studies which came out from China and from Russia, whereby they were showing that those women with low vitamin D levels tended to be the ones who are having more of miscarriages or failed implantation or recurrent pregnancy loss. But what we are seeing here, like you said, in India, even locally, with all the sun around, even in some of the arid areas, we still have several women with low vitamin D levels. And yet, yes, quite a number of virtually more than half of those who have got miscarriages, you'll find that they may have low vitamin D levels. And yet, those who have low vitamin D levels still carry out their pregnancy to term. We carried out a study with one of the residents just about 2.5 years ago amongst women with recurrent miscarriages. And the study analysis showed that there was no correlation, although we need to relook at that study in view of some of the new information coming about the role of vitamin.
So I think the vitamin D studies have showed
an aspect of recurrent pregnancy loss.
Yes, Professor, actually the vitamin D studies have shown an association, but the intervention studies have not shown giving or supplementing vitamin D reduces the adverse effects. So that is something which is there for a lot of vitamin D studies. You have associations with pregnancy loss, associations with polycystic ovary, associations with anemia. So vitamin D deficiency is rampant in India. It's 70 to 80%. It's as prevalent as anemia is, low hemoglobin in India. And so vitamin D supplementation is a norm in a preconception setting. It's like we give folic acid, we give vitamin D also. So it's something like that in a preconception setting. Yes, a lot of associations have been there, but not much of intervention giving vitamin D and resulting in a better outcome has not been shown in most of the studies. There's a question about, can a person losing 6 pregnancies have pregnancy again using progestogen, but progestogen is just a support. If you have 6 pregnancy losses, I think most of us would be giving any medicine under the sun. We will be just trying to make sure that she is pregnant. So you'll give HCG, you'll give progestogen, you give low molecular weight heparin, you'll give aspirin, you'll give everything, whatever is there. I think for a 6 pregnancy losses, people will generally be desperate. But of course, before that, you will do all the investigations which we have mentioned, so that you can rule out other causes which can be there. Role of cervical cerclage in a uterine septum. Well, there has been a lot of times we think about associations and congenital abnormalities of the uterus, that you will also have a cervical insufficiency, but recent studies have shown that is not always the case. So just because you have a Mullerian anomaly, that doesn't mean that you will have to have a cervical cerclage or an insufficient cervical insufficiency. Cervical insufficiency, generally we have understood, is a dynamic subject which will only be prominent during the time of pregnancy. So it's not something which we can always diagnose earlier, and that is the thing. Aspirin and heparin concurrently, yes, in most cases of diagnosed antiphospholipid antibody, we will be giving it. For how long? Again, after from the time you see the heartbeat till around 34 to 36 weeks.
Good. I can't see any more comments on the chat, Dr. Basa. I think maybe it's because you could have captured as much as you'd want to. Maybe I think also for sorry, since there's no question, I'm bringing in questions of interest. Maybe could you touch on, given a choice between dydrogesterone and micronized progesterone, especially the ones you use as a pessaries, the 400 milligrams vis-a-vis the dydrogesterone, what would be your take between the two? Because there's usually a lot of discussion of which one do you think is superior, which one would you want to use, given a choice?
Professor Omondi, that's $1 million question which you have kept. And in India also, we have different forums where we keep on discussing this, and the final word is not out. Though a lot of the studies have been done with micronized progestogen mainly, but a lot of us think that oral dydrogesterone makes more sense in a woman who's bleeding in pregnancy, because if a bleeding woman, how will she put a vaginal pessary? How the pessary would be more of an irritant? These are some things which we often assume. But again, it depends on the woman. Both are effective, but a lot of people do think that oral dydrogesterone may have an edge, but we still are waiting trials on head-on oral dydrogesterone versus vaginal micronized progestogen. But one thing is certain, there are some people in our country, I'm sure in yours, who use micronized progestogen orally, and there is no role of oral micronized progestogen. So it has to be used vaginally for an effect out there. And if you're giving oral, the only thing you give oral is dydrogesterone. So I don't have an answer, Professor, to your question, which is better. We use both, but at the same time, I think we still have to wait for more trials to see which one would be more. But recommendations have come in for both, and more for micronized progestogen than oral dydrogesterone in the Western literature.
True. I think there's also a lot of misuse of medication, as you have indicated. You find that there are those who think that by loading the patient of too much of the progestogen, whereby you give your micronized progestogen, you give it PV, then you find that they'll also give a mixed concurrently dydrogesterone at the same time orally. And I've seen some patients who are mentioning this for learning purposes, whereby at the same time, they are also given depot progestogen injection. So one person is being loaded with too much of progestogen in the belief that higher doses giving them at different routes will give you a better result, which is really not the case. I think the idea is choose the one you're using, give the adequate dosaging, and then monitor the patient's progress. I think also what Dr. Basa, from what you have said, the take-home message is that by giving this medication, it does not necessarily mean that, okay, we gave the medication, it didn't work. There are those situations, because when you are dealing with a bleeding patient who is already having an early pregnancy, there are those who are destined to lose that pregnancy. Irrespective of what you use, they may still be able to lose the pregnancy because of what the embryo is all about. And therefore, you may not be able to start blaming the medication which you used, that I used a medication which would, if I'd used one, would have been superior. But it's the essence of the treatment, the timing of the treatment, the cause of the bleeding, and the cooperation of the patient, I think all are encompassed in one to give you a good outcome in this patient, so that you have got a better take-home baby rate in this patient. Thank you.
Thank you, Professor.
I think one last question from Jean Didiu. Oh, there are two more. Maybe you can look at those two more. It's already 8:06. I know it's about 10:30 at in your home.
So does aspirin help in cases of pregnancy loss where it's difficult to do investigations? Can it be combined with heparin? So unexplained pregnancy loss, there is not shown to be an effect of aspirin and heparin together. But low-dose aspirin, there are nice guidelines where there are several situations in a pregnancy where you can consider low-dose aspirin. If it's an elderly mother, if it's an IVF pregnancy, if she's got pre-existing diabetes, there is a long list of some conditions in pregnancy where low-dose aspirin would possibly help, but not with the heparin in an unexplained pregnancy loss, just to try to hold on to something. There's not much of evidence, but again, as I said, not everything that we practice in our clinical practice is evidence. Some of it is experience, some of it is discussion with the patient at that point of time, what you think is right. You will not be going through the guidelines and jumping, but we will have our individual opinion at one point of time, and that is also something which we need to respect. And Mr. Hassan Sheikh talks about pregnancy. If a patient had first pregnancy loss at second trimester, having recurrent spotting in the second pregnancy and occasional bleed in the first, started progestogen until 34 weeks and delivered a healthy baby at 40 weeks. I think a big clap to you, Dr. Hassan Sheikh. And I think that is a story where what we want to say, that progestogen definitely has one of the important roles, and we have discussed that today. Thank you for sharing that case with us. And I think that is important.
Thank you, Dr. Bassa. I don't see any more questions on the chat. So maybe at this point, you might be able to call it a day, since there's no other question. Mr. Shock, do you have a comment to make before we close the session? Or your local representative, Rajesh?
Sir, first of all, we would like to say thanks to you and the whole KOGS association in Kenya and all other your colleagues and friends from across East Africa, Uganda, Malawi, Zambia, who are there on this call. We are overwhelmed by the number of practitioners who attended this meeting. This is really much more than the expectation. And we are also very, very thankful to Dr. Basab Mukherjee, who agreed to this invitation and who obliged us and who could spare his very busy time from at this hour of time, especially in India. It was very late by any standard. So thanks a lot, Dr. Basab Mukherjee, for attending this and for enlightening all of us and for conversing with this elite forum from these countries. So we are highly, highly thankful to each one of you, and we are really, really obliged. And this gives us a more encouragement to have more such kind of interactions with the Indian speakers or participants and other participants from across Africa. I think these are really good examples to go ahead with more such kind of activities. Thanks a lot, everybody. Thanks a lot.
Just one point, Mr. Ashok. I think some people have asked for the presentation. I'll be mailing it to you and Mr. Rajesh, and so anybody would be in touch with your representatives there would be happy. I'll be very happy to share it with any of the participants who would like to go through it. Thank you very much.
Sure, sir. We'll share it with Professor Omondi. And
it's been a pleasure to be interacting with you. Thank you, Prof. Thank you, Ashok. Thank you.
Thank you. Thank you.
Thank you all, and thank you for, because this was an ex-KOGS meeting, almost East, Central, and Southern Africa Member Society of Obstetricians and Gynecologists were all here from Tanzania, Mwanza, Zambia, Malawi, Uganda. I hope I saw one from Ethiopia. So this is the kind of reach which we would like to have, so that when we have got webinars of this nature, we share information across, so that all of us, because we are treating the same women in the same region, information is power. The more we know, the better our women will be able to benefit. And this is all in improving the health status and the well-being of the women in our region. Thank you so much to Dr. Basa for such a good presentation. Like I said, you made it simple, nice, and sweet, and everybody was able to take home enough info to be able to help them in their practice tomorrow morning. Ashok and your team, thank you so much for having made this webinar possible. Initially, we thought the notice was short, but the participants were many.
No, sir, it's all for your initiative, sir, and it's all your encouragement that you took it so enthusiastically, and you involved us in this. It's all because of you, sir. It's all your initiation. I'll say the whole credit goes to you, sir. And we would love to associate with you more frequently going forward, sir. And we'll be more than happy to participate and arrange such kind of sessions.
You are most welcome. It's all because this is a subject which is close to my heart, is what I do most of the day. So thank you so much. And to you all, those who took time to be able to share their time in this webinar, please, you're most welcome. We hope the next one will be there soon, and you'll all be invited. And lastly, thanks to KOGS and your Mr. Ashok, your local committee headed by Mr. Rajesh. Kudos to you all. And thank you, and have a nice evening. God bless you all.
Thank you, sir. Thank you.
Thank you, Professor.
Have a nice evening, sir. Bye, sir.
Okay, bye.